Good morning, everyone. I, Dr. Somyashri Samal, am going to present a case of an unusual presentation of craniopharyngioma, no financial disclosure. So, my patient, 22-year-old male from Kendrapada, Odisha, came with a complaint of diminution of vision in both eyes, left more than right, for the past 5 years, which got worsened over the last 20 days. It was associated with intermittent headache and vomiting. Proper history and detailed examination revealed features of hypogonadotropic hypogonadism with hyposmia, growth retardation and delayed puberty. BMI was 17.9. On ocular examination, right eye best corrected visual acuity was 6 by 24 parts. Left eye BCVA was hand movement positive. Color vision contrast sensitivity was not assessed. There was mild to moderate ptosis. Pupil showed grade 2 RAPD. On strabismus workup, Hirschberg corneal reflex test showed 7-degree left exotropia, modified Krimsky test showed 12 prism diopter left exotropia. Fundus finding of both eye showed diffuse disc pallor. HVF finding 24-2 of right eye showed temporal hemianopia, left eye was not assessed due to low vision. So interpretation was presumed junctional scotoma. Then we came to a provisional diagnosis of both eye optic atrophy with left eye mild to moderate ptosis, sensory exotropia with presumed junctional scotoma to rule out chiasmal compression, cellular or supracellular or infracellular lesion, Kalman syndrome to rule out. Then we went for neuroimaging and laboratory workup. Medicine and ENT consultation was done to confirm diagnosis of Kalman syndrome. Contrast enhanced MRI brain and orbit showed large lobulated peripherally enhancing cystic lesion involving the cellular and supracellular region, iso to hypointense on T1 and hyperintense on T2 and FLAIR sequences, with heterogeneous post-contrast enhancement compressing the optic chiasm and tract and protruding into the third ventricle suggestive of craniopharyngioma. Laboratory investigation showed increased level of prolactin, decreased serum TSH, FSH, LH, IGF-1 and growth hormone. Then with the following neuroimaging and laboratory workup, we came to a final diagnosis of both eye optic atrophy with left eye mild to moderate ptosis, sensory exotropia with presumed junctional scotoma suggestive of craniopharyngioma, hyposmia with hypogonadotropic hypogonadism in Kalman syndrome. He underwent right terional craniotomy with subtotal decompression of the tumor. Specimen was sent for biopsy, showed adamantinomatous craniopharyngioma. Then he was prescribed hormone replacement therapy and adjuvant radiotherapy. Craniopharyngioma is the third most common intracranial tumor of the childhood and adolescence. Presenting features are diminution of vision, headache, nausea, vomiting, bitemporal hemianopia. Adamantinomatous subtype is the most commonly found in the pediatric age group. Compression of the neurovascular structure can lead to endocrine disorder, visual loss, and then raise intracranial pressure. Hypopituitarism leading to delayed puberty is a very rare manifestation of craniopharyngioma. Hormonal assay can very rarely reveal deficiency of growth hormone, follicle stimulating hormone, and luteinizing hormone, resulting in growth failure and delayed puberty. Kalman syndrome is a congenital form of hypogonadotropic hypogonadism that manifests with hypoanosmia. It affects 1 in 48,000 individuals. There is failure in differentiation or migration of the neuron that arise embryologically in the olfactory mucosa. Association of craniopharyngioma with Kalman syndrome is a very rarely reported entity. Delayed puberty and hypogonadotropic hypogonadism along with stunted growth in our patient could be because of combined effect of craniopharyngioma and Kalman syndrome. Uniqueness in our case is delayed puberty and features of hypogonadotropic hypogonadism along with hyposmia and stunted growth in patient with craniopharyngioma. Co-presence of Kalman syndrome is an incidental diagnosis, very rarely reported entity. So role of ophthalmologist in meticulous history taking, thorough systemic examination along with ocular examination signifies evaluate the patient as a whole, not the eyes only. So my take-home message will be in patient presenting with signs of hypopituitarism, including delayed puberty and short stature, craniopharyngioma should be suspected when diagnosing tumor in cellular or supracellular region. Craniopharyngioma are typically accompanied by neuroendocrine dysfunction. Their proximity to vital neurovascular structure most commonly indicates microsurgical intervention. Features of hyposmia along with hypogonadotropic hypogonadism in addition to hypopituitarism can lead to high suspicion of co-presence of Kalman syndrome in patient with craniopharyngioma. Though the simultaneous presence of these two disease entity in the same individual is a coincidental finding, thorough systemic evaluation and proper laboratory investigation help us in arriving at the correct diagnosis. These are my references. Thank you.
well-documented case, and one should always remember these cases.
Yes, sir.
Even if they're mild pallor with the hormonal changes, one should suspect some problem in the brain,
Yes, sir.
hypophyseal region. One should have a good MRI,
MRI, yes,
because
sir.
this case has almost involved the third ventricle.
Yes,
So
sir.
naturally, now concentration is only on the survival of the patient.
Yeah.
So they require a good neurosurgery.
Yes.
Then only they survive. Otherwise, their life will be at danger.
Yes, sir.
So that is what the role of an ophthalmologist, to identify early any pallor, any other changes. Immediately you think of the intracranial problem, not just because some glaucoma. There are
Yes, sir.
patients. There are patients